Multiple sclerosis, or MS, is a chronic disease of the brain and spinal cord that affects more than 400,000 Americans, typically young adults in the prime of their lives. Two-thirds of those affected are women, mostly people of Northern European ancestry. In this video, we will talk about our current understanding of the disease, what it does, and how it affects the functions of the central nervous system, that is, the brain and spinal cord. After describing what is MS, we will talk about how the disease is diagnosed, the different patterns of the disease, and what treatments are currently available.
When I was newly diagnosed, I was very frightened. I didn't know what course the disease would take or how long the symptoms would last. I thought I had a death sentence. I started to read up on the disease. The unpredictability was what scared me the most. Any little symptom, whether it really is related to MS or not, gets your attention. You want a direct line to the doctor's office to air your concerns. Support from my husband and family was crucial and really helped me through my worries.
I knew quite a bit about the disease since my mother lived with it for 40 years. The main thing I knew was that the disease affects each person differently.
I remember when my doctor first told me that he thought I had MS. I called my husband on the phone and said something like, "Will you still love me if I have to use a wheelchair?" I didn't know much about MS at all. I guess I was probably like most people. I thought that if you had MS, you automatically used a wheelchair. I didn't know that most people with the disease are not significantly disabled. I didn't know you could be like me, healthy, active, and physically strong. At first, I thought my life was over. As it turns out, it was just beginning.
MS is an inflammatory disease of the central nervous system in which the body's immune system attacks healthy parts of the brain and spinal cord, causing tissue destruction. The inflammation of MS occurs in patches, so not all of the brain or spinal cord is affected at once. These patches of inflammation initially affect the insulation around nerve fibers called myelin. Myelin is made by nerve cells called oligodendrocytes, or oligos. Since the central nervous system is an electrical organ, proper insulation of nerves is necessary for electrical impulses to be sent quickly and accurately from one point of the system to another. Loss of myelin, or demyelination of nerve fibers, occurs because lymphocytes, part of the body's immune defense system, cross the blood-brain barrier and enter the central nervous system. These lymphocytes are then stimulated by proteins in the brain and produce toxins that attack myelin. The myelin becomes damaged, and scavenger cells called macrophages strip the damaged myelin from the nerve fibers. When the myelin insulation is destroyed, nerve impulses take longer to reach their destination and in some instances are blocked. When this happens, particular functions of the brain and spinal cord may be interrupted. As the toxins and macrophages continue to destroy myelin, the underlying nerve fibers become exposed, and they themselves are eventually cut. People often ask if myelin and nerve fibers can be repaired. To a limited extent, they can be, but only after the inflammation has subsided. Oligos try to form new myelin layers. However, in areas of inflammation, oligos don't grow and often will die. As a result, formation of new myelin is very reduced and often absent. Nerve fibers that have been cut cannot regrow. If the inflammation in MS lesions is very intense, there is little, if any, regeneration, and permanent scars are formed. These scars are called plaques.
MS is a very complex and variable disease. And because it can affect any part of the central nervous system, each individual's symptoms are unique. It's been my experience that most people, when they hear the term MS, have an image of wheelchairs and significant disability. And while this can certainly happen, it is relatively uncommon. In actuality, most people with MS have mild to moderate changes in their ability to function and can lead relatively normal lives with normal lifespans. In addition, with the advent of treatments for MS only available in the last decade, the course of MS can be significantly altered for the better. In every instance, early diagnosis and treatment are critical.
There are 4 general patterns of disease in MS. The most common pattern is one of attacks and remissions. This pattern is called relapsing remitting MS. In this pattern, an individual will have the fairly sudden appearance of a new symptom, often within hours to days, with gradual improvement over days to weeks. Since MS can affect any part of the central nervous system, the number of symptoms that can occur is quite large. They can range from changes in vision, to feelings of numbness and tingling, to difficulties with strength, balance, and coordination, to changes in bowel, bladder, or sexual function. The second pattern of MS is called secondary progressive MS. This pattern gradually develops in about 1/2 of individuals who originally had relapsing remitting MS. In secondary progressive MS, a person no longer has sudden attacks. Instead, there is a gradual and continuous progression of neurologic change. We don't know why the pattern of disease changes in this way, but we do know that persons with this pattern do not respond well, if at all, to treatments that have a reasonable effect on relapsing remitting MS. The last 2 patterns of MS are the least common: primary progressive MS and progressive relapsing MS. These patterns occur in only 10 to 15% of persons with MS, and unlike relapsing remitting MS, are seen in individuals in their middle years, with equal numbers of men and women affected. The pattern of primary progressive MS is one of very gradual onset of neurologic change, often affecting the legs, with increasing difficulties over years and decades, and no sudden attacks or relapses. In progressive relapsing MS, onset is gradual, with an occasional acute attack. Unfortunately, there is no proven therapy for these last 2 patterns of MS, and management of symptoms remains the only option at this time.
I have a chronic progressive type of MS with a relatively low slope of increased disability over time. I've now lived with MS for about as long as I have lived without it, and have learned to cope pretty well. MS has affected the strength in my right leg. I walk with a limp, but generally get where I need to go. The good and bad days that I have are largely psychological. Sometimes I feel sorry that I cannot do some of the things I would like to do, but who can do it all? I know that if it were not for the support of my wife and children, there would be far more dwelling on the negative than the positive, and a much less fulfilling life.
No symptom or sign is unique to multiple sclerosis, and diseases that can mimic MS must be ruled out before a diagnosis of this disease can be made.
When I first went to the neurologist, he did not diagnose MS for sure. He only said that it was a possibility. He eliminated some possibilities by doing a spinal tap. The MRI didn't show MS to an absolute certainty, but the doctor gave it an 85% chance. My most memorable feeling was pissed off, because I have always taken very good care of myself. 5 years later, my husband and I were reading about MS treatments, and he suggested that I get another MRI to be absolutely certain that MS is what I had. They read the MRI and confirmed the illness.
Because of the difficulty in diagnosing someone with MS, it is important to obtain as much objective evidence as possible. There are many individuals that have symptoms suggestive of MS, but in the absence of objective findings showing the presence of patchy brain inflammation, a diagnosis cannot be made. Objective findings include a neurologic exam, MRIs of the brain and spinal cord, blood tests, and testing the spinal fluid. In order to be diagnosed with MS, an individual must exhibit all three of the following: a progressive inflammatory disease of the central nervous system, involvement of different areas of the central nervous system, and most importantly, that the findings cannot be explained by other illnesses. Let's talk about the use of MRI in diagnosing MS and its value in following the course of the disease and response to treatment. The MRI scan uses magnetic and radio waves to look for changes in water content within the brain. No X-rays are involved. MRI cannot detect why the change occurred, when it occurred, or what the underlying tissue changes actually are. In other words, the changes seen on MRI are nonspecific to any particular disease. As a result, lesions seen on MRI can occur with illnesses as different as high blood pressure, normal aging, migraine, stroke, infections, tumors, and of course MS. However, there are certain types and locations of lesions that are very suggestive of MS, and their presence would support such a diagnosis. It is important to remember that there is only weak correlation between the changes seen on MRI and the degree of difficulty a person with MS is having. What is more important is where the lesions are located and whether they are especially destructive. After we have diagnosed a person with MS, the MRI becomes a valuable tool for monitoring the effect of treatment on their disease. Indeed, in our clinic, we perform MRIs of the head and often the spinal cord on a regular basis to follow the effects of an individual's treatment and, if appropriate, modulate or change their therapy.
Today, MS is not a big part of my life. But when I was first diagnosed, I couldn't stop thinking about it. I think most people would have expected me to say that I wish I didn't have MS, but that's not true. Having this disease has made me feel grateful for things that I might have taken for granted before. It's also made me stronger and capable of putting smaller challenges in perspective.
There are three general categories of treatment for MS. One is for treating the acute attack or relapse. Two involves symptom management. And three utilizes immune modulating therapies that affect the long-term course of the disease. Since attacks of MS are the result of acute inflammation of the central nervous system, initial treatment is aimed at reducing the amount of inflammation, shortening the duration of the episode, and promoting healing. To do this, steroids, a powerful class of anti-inflammatory drugs, are administered. Steroids can be given either by mouth or by vein. The amount of drug given and the duration of treatment will vary with the severity of the attack and the response in the patient. Responses may not occur immediately, and delays in seeing benefit from these drugs is fairly common. While steroids have been shown to have an effect on the short-term course of MS, the value of their long-term use still remains controversial. There are many difficulties persons with MS may experience. These include muscle tightness or spasticity, overwhelming fatigue, bowel and bladder changes, tremors, and changes in mood, especially depression. There are no cures for many of these difficulties. There are a multitude of treatments in the form of medications, devices, and therapies that can decrease symptoms to a significant extent, allowing a person with MS to function at their highest level. A survey of neurologists indicated that management of symptoms is often overlooked or not fully explored. Discussing symptom management with your neurologist is a vital part of your treatment and should not be overlooked in the rush to treat with disease-modifying drugs.
Among the most important areas of symptom management is exercise and maintaining good physical condition. In my experience, the results of regular exercise can be quite impressive, with major reductions in fatigue, better mood, and greater ability to function within the limits imposed by one's MS. There is no one set or kind of exercise that persons with MS should do. Use common sense and gear any exercise program to your abilities. I urge you to avoid overheating, dehydration, and overdoing it. Indeed, my motto is, when you think you can do more, stop. I'm sure that many of you may be thinking, he's out of his mind. How can I exercise when I'm so tired, so weak, so busy, so stressed out? And you're right. You are fatigued, weak, busy, and stressed, but it's exactly these difficulties that regular exercise can address. Why fight both MS and being deconditioned? Start somewhere, keep it simple, and do it regularly. Free weights, exercise machines, push-ups, taking a walk, anything to tone muscles and keep you limber is going to help. To paraphrase a well-known saying, just say yes to exercise and you'll be pleasantly surprised.
There are treatments for many of the physical and emotional symptoms of MS. The disease clearly will take what you give it, and the key, of course, is to give it as little as possible. Stay involved. With the support of family and friends and the broader community, the disease can be managed, and a very fulfilling life is possible.
The last 10 years have seen major advances in the treatment of persons with MS, especially those with the most common type of MS, relapsing remitting. These treatments, all of which are drugs that modify immune function, are based on the fact that early in the course of the disease, inflammation by the immune system has a major role in the destruction of myelin. As the disease progresses, other non-immune factors play an increasing role in myelin loss. And because of this, the current disease-modifying drugs have their greatest benefit early in the course of the disease. It's important to remember that these drugs are not cures, and disease activity can still occur even while on them. In addition, the drugs cannot reverse damage that has already occurred. Their role is preventative and hopefully disease stabilizing. All of the disease-modifying drugs decrease numbers of relapses, reduce the severity of attacks, and decrease numbers of new lesions on MRI. In some instances, they may even allow greater healing of brain lesions. It's known that none of the disease-modifying drugs have an immediate effect on the course of the disease. They show their effects over a period of months and even years. In addition, there are large differences in how people respond to drugs. Some respond very well, and others may show very little change. It's not enough merely to start one of the disease-modifying drugs. Careful monitoring of your illness and working closely with your physician are equally important. At present, all of the disease-modifying drugs are administered by injection. I know there has to be a better way, but let me assure you that scientists are trying very hard to find an effective drug that can be given as a pill. For patients with relapsing or remitting MS, there are two categories of disease-modifying drugs, the interferon betas and glatiramer acetate, or GA. Each is different in its mode of action and in the variety of side effects it may have. Choosing one or the other can be very difficult, especially since there's no way of knowing what drug may be most effective in an individual. Indeed, the best way to choose which drug to begin treatment with is by first understanding what each drug can and cannot do, how it works, and what side effects it may have.
Beta interferon is a normal body substance we all make during times of infection and inflammation. We know it is a substance that affects the immune system in a variety of ways, but we don't know which ways are important in terms of its benefit to persons with MS. Beta interferons have a rapid effect on acute inflammation in the brain and have been shown to reduce the number of MS relapses by 18 to 33%, to reduce numbers of lesions in the central nervous system, and possibly to delay progression of disability. At present, there are 3 brands of beta interferon approved for use in the US. Betaseron, which was the first of the approved disease-modifying drugs, Avonex, and Rebif. Avonex and Rebif are the same drug, but with major differences in dosage and frequency of injection. All beta interferons have the potential to cause flu-like symptoms when first used. In most persons, these side effects decreases over time and are well controlled by slowly increasing the dosage of the drug and taking over-the-counter pain relievers. Other side effects include changes in blood count and liver function, changes in thyroid function, and depression. All of these side effects should be carefully monitored by your neurologist, since changes in drug dosage may be needed to allow improvement.
I want to briefly mention one of the more controversial issues regarding beta interferons, and that is the role of neutralizing antibodies. Now, it's known that any injected drug can induce antibodies, but in the case of injection with beta interferons, most people make small amounts of antibody that are there for a short time and then seem to disappear. However, in about 10 to 15% of patients, the amounts of antibodies that are made are high and remain so for years. There is new research that indicates that persistently high amounts of such neutralizing antibodies to beta interferon significantly decrease the drug's effectiveness. I do not routinely check for neutralizing antibodies to beta interferon. However, if a person is on one of the beta interferons and begins to have a worsening of their MS where they previously had been stable, or their MRIs show an increase in new lesions, this could be the result of high levels of neutralizing antibody, and I will look for them at that time. If they are present, I will consider changing treatment for that person from a beta interferon to glatiramer acetate.
Glatiramer acetate, which is marketed under the trade name Copaxone, was originally created about 30 years ago with the intent of causing an MS-like illness in experimental animals. Rather than cause this illness, animals were protected from it, and clinical trials in people with MS began. It is not known exactly how Copaxone works, but it appears to interact with cells of the immune system that respond to myelin. By interacting with Copaxone, the immune cells change their responses from one of myelin destruction to one of myelin protection. Cells respond to Copaxone also make substances called trophic factors that could allow nerve cells to heal. In clinical trials with Copaxone, the drug can reduce relapses by about 30%, decrease the number of actively inflamed lesions on MRI, and decrease the number of new lesions on MRI. Long-term data with Copaxone showed that in groups of patients responding well to the drug, the beneficial effects appear to be sustained for as long as 10 years. Copaxone side effects consist of injection site itching, burning, and swelling. Once in a while, there can be a systemic reaction. This consists of the sudden onset, within seconds of injecting the drug, of a hot, flushed feeling coupled with heart palpitations and intense shortness of breath. However, within minutes to half an hour, the feelings subside without after effects. The reasons of this uncommon reaction are not known, but they could be the result of an inadvertent injection of the drug into a small vein. There is no need to monitor blood counts, thyroid, or liver functions in persons taking Copaxone, and while persons taking the drug make antibodies to Copaxone, there are no clear data indicating that these antibodies have a negative impact on Copaxone's effectiveness. The only drug approved by the FDA for use in persons with rapidly progressive MS and secondary progressive MS is the cancer drug mitoxantrone, which is marketed under the name Novantrone. Novantrone is administered intravenously once every 3 months for a maximum of 2 years. It has a broad effect on the immune system, decreasing the activity of all immune cells. Like all the disease-modifying drugs, it does not stop the disease, but decreases the rate of progression. It also has an effect on acute inflammation of the brain, as seen on MRI, and in reducing the number of relapses. Novantrone has potential short-term and long-term toxicities. In the short term, it can cause fatigue and nausea, and since it reduces the number of immune cells for several weeks, the risk of infection during that time is also increased. Novantrone cannot be given for longer than 2 years or beyond a certain total dosage because of potential effects on the heart that can cause heart failure. Before and during treatment, measurement of heart function is very important, and the drug may need to be stopped or the amount of drug reduced if there are signs that heart function is decreasing. Patients with relapsing remitting MS can also be treated with Novantrone.
For over 35 years, I've been involved in the research, care, and treatment of persons with MS. And I can't remember when I've seen so much promise for improving treatment and finding a cure for the disease. The past 10 years have seen the introduction of a remarkable arsenal of drug treatments that have greatly reduced the suffering of MS patients. For all those living with MS, I want to share with you some simple steps that have been most effective in dealing with your illness. Number 1, start drug treatment early. Number 2, maintain a good healthy diet. Number 3, use supplemental vitamins sparingly. Number 4, make exercise a priority in your life. And most importantly, please work closely with your doctor.
Since I found out I had MS, I've given birth to 2 wonderful children, pursued a challenging career, wrote a book, have a happy family life, and made many friends. I made the decision to continue living my life despite MS. You can too.
Don't be ignorant about this disease. Read up on it. Know your limitations and work with it. It is not a death sentence. It is just a challenge that you can overcome.